See if we can make that work. All right, that's fantastic. Thanks so much. I was sitting listening to Dr. Fagan talk, thinking I work at a pretty cool place. We've got a lot of folks studying thyroid cancer, and a lot of folks interested in this, and so it's no surprise that I'll be sharing some of the work from the same group of folks that Jim had talked about, including our endocrinologist, our pathologist, our radiologist. It's amazing to work in a place with so many people focused on one disease. The disclosure for this one, I'm going to touch on just at the very end, a little touch about lasers for the papillary microcarcinomas, but just in a brief passing, we have a research support for that. Well, today we're going to talk for the next sort of 20 minutes or so about sort of the active surveillance approach for indolent papillary cancer. And as I was thinking about this, I realized that there's a long sort of history at Memorial of why we would have been open to watching these papillary microcarcinomas. All of us at practice there have had experience of watching thyroid cancers that were diagnosed at the same time as a leukemia or a lymphoma, colon cancer, breast cancer, where it was clear we just had to wait on the papillary cancer while the other cancers were treated. These are not always low-risk cancers. These are 2 or 3 centimeter papillaries, sometimes with lymph node metastasis, that we learned that we could watch, and amazingly, most of them did well. We learned from the RAI refractory distant metastasis space, not every one of those needs to immediately go on some sort of targeted therapy. We watch a lot of those. Then about 20 years ago, we started watching small volume lymph node metastasis that was really detected because of our minimal disease detection with ultrasounds and TGs, and have watched those for years and years. And of course, we were comfortable following these little small nodules. I think one of the other focuses, Memorial has always been focused on understanding the natural history of thyroid cancer. I remember I'd been at Memorial, I guess I got here 23 years ago. In my first couple of weeks here, Jayton Shaw, who was the chief of surgery at the time, said, look, Michael, treating thyroid cancer is not that hard. You just have to understand the natural history. What is the natural history of this disease? That coupled with our minimalistic management approach, where our surgeons have been champions for decades and decades of lobectomy and not doing prophylactic neck dissections, and being really clear if we were doing something more aggressive once we got out of that commando approach in the 1960s. It's no surprise that when we began to learn about Professor Miyachi's experience, this rang true to us. That we said, yes, we can watch papillary microcarcinomas. We've been watching distant mets. We've been watching lymph node metastasis. We've been watching bigger tumors. And I very fortunately had the opportunity now, good grief, probably 10 years ago or longer now, to go visit Akira and actually look at his setup. And I remember him showing me ultrasound after ultrasound after ultrasound of patients he'd been following for 5 years and 10 years to show us how to do it. This is a summary of what he's shown. Now, these are papillary microcarcinoma patients. We're not talking about medullary. We're not talking about follicular lesions. These are papillary microcarcinoma patients, in his experience, all biopsied. And one of the first things that you see is about half the patients chose to watch and about half chose surgery. And this is in a program that he's president of the hospital and he's chief of surgery. Nobody can be more motivated. And yet still we're getting the hint that not every patient wants to follow with that. And not every surgeon is on board with that. But about half the group did. And at the time of this study, nearly 90% or more continued to watch. Here's about 2% that gradually increased in size over a few years. And he's used as a 3 millimeters or more change in size. And a little less than 1% get novel lymph node metastasis. I think the most important part of his studies was not only teaching us this was possible and that it was safe, but most importantly, that salvage therapy was very effective. In the few that grew, in the few that changed their mind and wanted treatment later on, in the few that had lymph node metastasis, they were all cured. Most of them didn't need radioactive iodine. Many of them treated with minimalistic approaches. And so we can feel comfortable, at least in the short term, that these folks are going to do fine. Well, despite facing a lot of opposition early on, Dr. Miyachi eventually won the day and convinced a lot of us around the world that this was just not something that could happen in Japan, but could happen in many other countries that you'll see here from Europe and from South America, and fairly consistent findings. How many will increase more than 3 millimeters? In the 5% range thereabouts. How many will develop some lymph node metastasis over time? 2 or 3%, depending on how long that you follow. So when we began to implement this, I was very fortunate to have JP Brito as a thyroid cancer fellow with me. Came down to spend a year and a half or so with us before going back to the Mayo Clinic. And it was right in the early experience with him and Mark Pace with me from Australia, as we were trying to figure out how we were going to implement this watching program. And as we talked about these cases day after day, I realized that there were really sort of 3 characteristics that we were using to decide, is this person ideal for active surveillance? Are they appropriate, or are they really inappropriate? Because as you can imagine, patients began to seek us out that did not want a surgery, and they wanted to watch, and they were not appropriate for that. And so as we worked with Professor Miyauchi and Professor Ito, they'd already done more than 2,000 patients. So I emailed them and said, hey, can you help me sort of think through this? How should we begin to put these together? And we realized here's the 3 groups of things we were thinking about. What were the tumor and the ultrasound characteristics? That was easy because we know what the ultrasound looks like. What were the medical team characteristics? Who needed to be involved? And what kind of radiographers did you need? And expertise in the ultrasound skill and cytology skill and reading the slides, and which ones did you biopsy? And then the most interesting one, as Dr. Van Nostrand mentioned this morning, were these patient characteristics. And that's what I ran into Pam Hartzbam's work on minimalistic and maximalistic patients. One of my favorite stories is a nurse that actually worked at Memorial. And on a Thursday morning, she had an ultrasound that showed a 6 or 7 millimeter suspicious nodule. She worked her way into pathology that afternoon to get a biopsy and have the slides read. And by Friday morning, she knew she had a papillary microcarcinoma. And she walked over to the clinic that Dr. Shaha and I run down the hallway from each other together to be evaluated. We said, yes, it's a thyroid cancer. We can fix this. Before I asked her if she was interested in watching with observation, she mentioned that she hadn't had anything to eat or drink all morning, just in case Dr. Shaha wanted to do the surgery that afternoon. When I asked her about observation, she pointed out she'd already been watching for 18 hours. That was enough. She wanted surgery. And that was my first indication that really, really smart lady, nurse, understood the system, understood she's a Memorial. She trusts us. No way on the planet she was going to watch. She was clearly a maximalist. And then other people are minimalists. The other important part is I should put in here physician characteristics as well, because each of us carries our own bias. It's probably no surprise that I'm a minimalist. I trained under some maximalists, but my openness, my willingness, my ability to sort of adapt to the Memorial philosophy when I got here probably was a reflection of my minimalistic management approaches. Now, if we look at these tumor characteristics, there are a couple of things that's really important for us to understand. And one is it's the location of the tumor, that obviously it's easy to watch one if it's here in the middle. On the other hand, if it's already invading out the front of the thyroid, that's probably not going to be a good one to watch because that's already declaring its biologic behavior. Somebody had asked this morning about, are there some of these little ones that are more likely to have different mutations or more likely to be tall cell or more likely to be whatever? I think these are the ones, or they already have N1B disease when a 4 millimeter lymph nodes. Those are the ones that are already probably carrying those more worrisome mutations and displaying their biologic behavior right up front, even at 4 or 5 millimeters. Now, for reasons I don't entirely understand, these papillary microcarcinomas tend to disproportionately sort of arrange themselves subcapsular location. About 80% of these are over near the capsule. They're hardly ever too much. They are in the middle sometimes, but we got faced with this situation that we're wanting to follow cases that are near the edge of the thyroid. So it matters what's on the other side of that edge. And so as endocrinologists, who would have thought we would ever have to learn where recurrent laryngeal nerves run or where vagus nerves run and those sorts of things? But it's important for us because we all are used to thinking about the nerve on the left-hand side running in the tracheoesophageal groove, and that's absolutely correct. But look at this recurrent laryngeal nerve on the right-hand side. It's running behind the posterior aspect of the thyroid from lateral to medial as it's going this way. So if we're seeing nodules that are on the back side of the thyroid in the right lower pole, it's potential that they could be adjacent to the nerve there. Likewise, we've got the vagus running down this side. Rarely the vagus will run medial to the major vessels. And so you got to be careful about tumors in this location as well. Now, that doesn't mean that we wouldn't necessarily watch one of those areas, but if it's touching the capsule, that's probably not one we'd want to watch, and that wouldn't move us more toward a surgery. Now, to be fair, it's very unusual for a papillary microcarcinoma to invade the nerve. And with studies moving forward, we may find out that the risk and benefit of a surgery in that area may outweigh the risk of just watching a papillary microcarcinoma. But until that's worked out, I think still moving those patients to surgery is the better way to go. So what does it look like if we follow? So as a general rule, we do the ultrasound every 6 months for 2 years. That's a good start. It gives you 4 measurement points over the first 2 years. Most of the patients feel very comfortable with that approach. You're keeping an eye on them. We're reevaluating on each time they come back. What's the size? What's the location? If it's changing, how rapidly is it changing? Is the patient developing different preferences? Because they can change their mind anytime. We don't think TSH suppressive therapy is recommended. I think we do more harm than good with that. But we do want to avoid TSH stimulation. So keeping TSHs less than about 3 if we need to, but most of the time that's part of the endogenous function. Checking thyroid function test yearly is a good idea. Originally, I'd measured thyroglobulin years ago when we start this, but it's really clear that that's not helpful and we don't do that anymore. So what's the indication to change your mind? If you're watching, I'll show you in a minute, most of these stay the same size. And what Professor Miyachi had shown is he'd use this 3 millimeter cutoff, because that's a fairly well standard accepted, what's the coefficient of variation between reproducibility of measurements. If you measure it day after day, the same person, plus or minus 3 millimeters, depending on where you put the measurement. So anything that's less than that 3 millimeters, you can keep watching. If it increases more than 3 millimeters, then maybe you're thinking about a surgery. 3-dimensionally, if you're increasing 3 millimeters in 1 or 2 dimensions, that correlates with about a doubling of the tumor volume, about 100%. If we identify lymph node metastasis, if we identify what looks like invasion into that capsule, or if the patient changes their mind. Now, I will tell you there were some caveats that both Dr. Miyachi's group and Professor Ito's group and our group was doing as well, because we knew that there were some people that we could confirm the volume would increase about 50%. It was getting bigger in 2 dimensions, hadn't got to 3 millimeters yet, but sometimes if it was near the thyroid capsule or if it was a little larger tumor we were watching, or sometimes patient preference, once they knew it was growing, they wanted it out of there. And then conversely, we had the very minimalistic patients that said, look, I know it's 3 millimeters bigger, but it's still only 8 millimeters or 9 millimeters. Can you keep watching? And now I've seen a good number that got 3 millimeters bigger, but it took 5 years or 6 years or 7 years. So you get that rate of change over time. When is it time to intervene? So we've moved away from automatically doing surgery at 3 months, although that's where the most data is, and incorporating other things like location and tumor size and rate of change into this decision. Now, one of the things that helped us think about this is because, as I mentioned, we think about natural history. I hang out with the surgeons too much, so these nodules always seem like 3-dimensional structures to me. This is not an 8 millimeter nodule. It's an 8 by 7 by 6 millimeter nodule. It's a 3-dimensional nodule that we have to think about. And when we began to think about this in terms of volume, our data showed very much what now multiple places in the world have shown, that by volume, about 80% of these nodules, if you do volume plus or minus 50%, that's been the traditional number that was used for benign nodules, and that's what we used in this study. About 80% stay the same size, and over 2 or 3 years, about 12% will increase in size. And you can see here this 100% increase in volume. That would have been the ones that Dr. Miyachi said got 3 millimeters bigger, and that's about 5 or 6%. This group on the other side was interesting. We had about 7% decrease in size, and it's still unclear exactly why they're decreasing in size. We'll come back to that in a minute, but that's been a reproducible finding over many, many of the studies that have moved forward. The other thing that we were interested in is, because I'm a math geek, I'm always interested in these curves. We showed that, as has been showed since probably the 1950s, that when these tumors are growing, they grow along a very classic, steady exponential growth curve. Exponential not meaning rapid growth, but exponential meaning a math term that it's growing. These are log curves. So they're growing at whatever pace they grow, that's the pace they grow. This one doubling in about 3 years, this one doubling in about 4 years, this one not doubling at all. Well, we've moved on, and this is a new paper that's actually with the Department of Medicine editors right now. We've all signed off on it. It'll be submitted to Thyroid here in the next few weeks with the same big team we had before. Now we're up to about 483 patients as of the data lock at the beginning of last year. Same age group, sort of in their 50s, everything from 20 up to 89. We've got a substantial number of patients now, 25% or more than 100 patients that are bigger than papillary microcarcinomas. These are 1 to 1.5 centimeter. Here's the gender distribution that you would expect. The majority of these were papillary thyroid cancers, but we will include in this study Bethesda 5s as long as the ultrasound is highly suspicious by ATA or TI-RADS 5. And now our duration of follow-up is around 4 years in that ballpark. I think it's interesting just to take a look without really percentages or cumulative percentages and say, where are these people right now? The last time they saw me, as of back in January of last year, out of these 483 that started watching, and I'll mention all of these had followed for at least 6 months to get into this current data set, about 80% stayed on active surveillance. About 4% transferred over to their local follow-up after they'd been following with me for 3 or 4 years and everything was stable. So they moved over to their local endocrinologist around us here. A few died not related to thyroid cancer, largely because we're a cancer center of other malignancies. And we only lost to follow-up 8 patients, which is not bad out of 483. That left about 9% that went to surgery. Well, why did they go to surgery? Well, the vast majority that went to surgery, out of that 45, 36 of them went for some reason that led to possible progression of disease. So here we had about 21 of them had an increase in the size of the nodule. It had gotten 3 or 4 millimeters bigger. 5 of them had some new lymph node metastasis identified. About 8 of them had possible invasion into the thyroid capsule. Turns out not all of them did, but we were worried on the ultrasound that they might. 1 of them increased in size and had a new lymph node metastasis, and only 1 of them had a new papillary microcarcinoma on the other lobe, and she decided that was enough. So this is pretty much exactly what's been shown around the world. There were 9 people that went to surgery for reasons that weren't sort of directly cancer related. 3 of them because they were just too concerned to keep watching over the first few years. 2 of them had planned a delayed intervention. They're what I call my bridge to a better time. They wanted to do something else. Somebody was getting married, a bar mitzvah, something was happening. And so they knew they wanted thyroid surgery, but not at the indicated, not then, and we did it later. A few other odds and ends reasons. Somebody needed hyperparathyroidism. The one that drove me crazy was 1 patient, they refused to do a necessary kidney transplant because he had this untreated thyroid cancer, and so we had to take that out. If you look at these sort of patterns, the natural history, this is what we found, which most other people, here's the time to identifying a lymph node metastasis. We had about a 3 or 4%, and most of the time you pick those up around the 2 or 3 year time frame. Here's the time to increase in volume, and so that you can see this sort of natural progression. Some were growing a little bit more rapidly, some were growing slowly, and by the time we projected out to 10 years, about 18 or 19% will have grown. So yeah, I totally understand that only 5 or 6% will get bigger than 3 millimeters, but I think when you look at the ones that are going to change by volume, the ones that are going to need a therapy are going to be closer to 10 or 15%. The other interesting part of this data set is once you get enough of these patients, you start to see patterns. There are certain patterns about how their individual measurements vary over time. So let me show you a few real patients. So this is a 46-year-old Bethesda 6. We've been following her for now 8, 9 years. And these are just normal variations in their measurement, really no change there at all. Now, I'll mention to you, we're using 72% change in tumor volume. We used to use 50%. But there was a nice study, I'll show you at the bottom here in a minute, that showed in these papillary microcarcinomas, I think because their margins are irregular and these are small, the coefficient of repeated measurement variation is not 50%, it's more like 72%. So that's what we've used in this study. If here's the other type, this is a different pattern. This patient was basically growing from the first time we saw her, a straight exponential growth up over time, and went to surgery about 1.5 years later. That tumor was doubling every year. Here's one that was more slow, an older lady, Bethesda 6. This is a tumor volume doubling time of 7 years. And she's gone from 6 millimeters to 9 millimeters in 7 years. And we're actually still watching her because this is right in the middle of the thyroid. So 2 different growth patterns. The other thing that we saw, this is that decline that we saw down. And it's often this pattern. You do a biopsy, you get a decrease in 40 or 50%, and then you see this trail off over time. Now, I wonder how much of this decrease is part of the biopsy, because these are relatively small nodules. And when you stick needles into them 2 or 3 times, you can get decrease in the size. But that doesn't really explain this long trail out over time. So interesting to better understand that. Now, we saw 2 other patterns that were surprising. And Professor Miyauchi described this about 1 year ago, so it made me go look for it. And we've had a few patients now that were clearly growing. There's the exponential growth, and then they flattened off. So this was growing exponentially from 10 millimeters through 12 millimeters. And then we got to about 13 millimeters, and it's been stable now for 4 years. And then this is the one everybody's watched about, talked about. This is the one we've worried about. This is a patient that's been followed with me, stable all the way up through about 4 years, and then a sudden change in the growth. And now a tumor volume doubling time, some of the most rapid we've seen over about 0.7 years. He's the ultimate minimalist. He refused surgery for another couple years. This was just taken out this year. And not surprisingly, it's a poorly differentiated thyroid cancer. We do have that sample, and as you can imagine, it'll be going to Dr. Fagan's lab for analysis over the course of this year with some other samples. So what we did was we said, look, we're seeing at least 5 different patterns. What would these things look like? So here's the stable pattern that we're used to. An early increase in tumor volume, a later increase in tumor volume, an early increase followed by stability, and then the one everybody worries about, stability followed by an increase over time. So this is a composite figure that we're still working on to try to explain, if we take a bunch of patients that have less than 1.5 centimeter papillaries that we think are ideal or appropriate for observation, what's their cumulative incidence? So this is stats with cumulative incidence over either 5 years or 10 years. Now, most of our data runs out to about 4 or 5 years. So I think the 5-year data is most strong, but the 10-year data also gives us a little glimpse of the future. And what you see is if you look at who stays in the dark blue, by 5 years, nearly 80% are still in that stable pattern, and by 10 years, about 70%. So there's that 20 or 30% that are growing. Here's the group that we talked about decreasing in time, and that's not an insubstantial group. That's 5 to 10%. That may mean you have almost as many decreasing over time as you have increasing over time. And if that was the case, it would be a different discussion you had with the patient when you were trying to explain to them, you've got about a certain chance of increasing, a certain chance of decreasing. Then here's the early pattern that we saw in the first paper. These were the ones that were growing, and that's about 10% or so. You can pick those up around 18 months or so. And then here's the third pattern, which is the slower growing folks. Here's the one that was going up and that's flat. And here's the one case that was up over time. So as you think about how we find these patients, you can see now why it makes sense to do ultrasounds every 6 months for the first 2 years. You're trying to find these first 2 patterns right now. And if you're stable through that first 2 years, then you don't need to keep doing ultrasounds every year anymore, because the changes are going to be slower or they're going to be unpredictable. So this, I think, gives us rationale to ultrasounds every 6 months for the first 2 years, then kind of yearly after that. And then we'll have to decide, how do we have to keep following these patients forever to find the 1 in 500 or the 1 in 1,000 that changes, or what would that sort of follow-up look like? So when we began to think about what these management options would look like, this is what they would look like. that we would say, if it's stable, obviously continue active surveillance unless the patient is worried or changes their mind. If you have an early increase in tumor volume, that's probably going to take you to some sort of therapy, but depending on the rate and the location and the size, you may watch a little bit longer. The later increase, same sort of thing, probably going to take you to surgery, but depending on the size and the location and rate, you may watch a little bit longer. And then obviously, if you have stability, you're going to follow with active surveillance. And if they change over time, that's going to move you toward a surgery. Now, in just a minute, I'll mention to you, you'll see I use the word transition to a therapeutic intervention. Now, in the past, that was always a discussion of just lobectomy or total thyroidectomy. How much surgery should we do? My good friend, Dr. Volpe from Sao Paulo, is going to talk a little later this afternoon about these techniques for ablation and nodules and the things they're doing. I don't pretend to understand all that he's doing down there. It's amazing to see his slides and what he's doing. But there is now beginning to be an application, although I still think experimental, but an application in the thyroid cancer field. So that if we had small thyroid cancer nodules, could we have an alternative to destroy these little nodules that does not require a surgery? A brand new paper that just came out, led by Greg Randolph, and a consensus of everybody he could get around a virtual table at that point, that has a lot of information about benign and malignant thyroid disease. I point you to this paper. It's really very, very well done. If I look at just the experience in the papillary microcarcinomas, using microwaves, radiofrequency ablation, laser ablation, complete ablation of the zone is upwards of 100%. Recurrence rates are essentially zero, very little at all. Complication rates very mild, transient voice changes either from the hydrodissection or the heat or the procedure. So really no great long-term complications yet. There is a little caveat to killing cancer as opposed to benign nodules. On benign nodules, if we kill most of the middle or most of the nodule and it shrinks, we're happy. But in thyroid cancer nodules, like with all cancers that they do ablative therapies on, you need a safety margin of a couple millimeters around the nodule so that you can make sure the thyroid cancer is completely destroyed. And this is an example of one our team did. Small thyroid cancer in the lower lobe. They inject a little bit of saline and lidocaine to numb up the capsule and also to give a little heat barrier, and then can easily destroy the little nodule. So when I look at sort of the active surveillance story now, I think the real key is, like we've been talking for this entire meeting for 2 days, it's proper patient selection. Using that peri-diagnostic risk stratification that we talked about, that diagnosis from the time the nodule is found to decide, are these people appropriate, inappropriate, or ideal, thinking through each of these characteristics, and then understanding for that patient, is a minimalistic option reasonable? We don't want to swing too far. There are patients that absolutely need total thyroidectomy, radioactive iodine, and neck dissection, and we don't want to get into the trap of getting too far away from that. But there's also patients where that's incredible overtreatment. And in fact, lobectomy might be overtreatment. And so the options could be watching, thyroid surgery, or a localized ablation. In our hands for cancer now, still in a clinical trial, although I bet within the next 2 or 3 years, this will become a relatively standard of care management option. Thanks very much.